today's session. I'm Dr. Kimathi Philemon. I'm medical officer, senior medical officer, accident and emergency, Kenyatta National Hospital. I want to welcome you to today's webinar. We are going to continue with the clinical ethics series. In today's session, our topic is the escalation of care. It's a great pleasure to introduce our speaker for today, Dr. Jacqueline Wanjiru Kagima, a senior medical doctor, pulmonologist, and critical care specialist, and a member of KNH Clinical Ethics Committee. She's also a PhD holder and a passionate point-of-care ultrasound practitioner. She's going to talk to us about the de-escalation of care. With this, I want to welcome Dr. Kagima. Dr. Kagima, karibu.
Thank you so much, Dr. Kimathi. So allow me to share, if that's okay with you.
Yes, you can go ahead, Doc.
Can you all see the slides?
Yes, it's visible. You can go ahead.
Thank you so much for such a flowery introduction, Dr. Kimathi. I am really humbled. So I will go ahead and with today's discussion. And I just want to give a disclaimer that today's discussion is really not, I'm not presenting because I'm an expert in this, but I'm basically presenting because we face this every day in the critical care units. Every other day we are faced with this dilemma of de-escalation of care. So, and when I was looking at the data, I don't think anyone knows enough on the de-escalation of care, and we continue to learn. And this presentation might actually spark a few interesting thoughts or even discussions, and I'm happy to hear what the rest of the team feel. So I'm trying to move the slides. Yeah, there. So before we discuss de-escalation of care, I think we need to understand what is goals of care, because before we even start de-escalating it, we need to get the goals of care. And basically goals of care, you should have what we call goal concordant care. What that means is that this is basically clinical care that helps reach a patient identified goal. I want to make it very clear that goals of care are not primarily a clinician's goals of care intention. It's not, as a clinician, it's not what I want for the patient. It is more of a collective decision of what is best for the patient after discussion with the patient's relatives or the patient's next of kin. So goals of care, I want to make it very clear, it's that care that helps you reach a patient identified goal. So it has nothing to do with you as a clinician per se on your own. And I want to say that for us to have a very good goal concordant care, this is basically, you need to sufficiently provide prognostic awareness for the patients or their surrogate so that they understand what is expected. As a clinician, you are the expert, you provide all the details truthfully on their treatments, their survival, and subsequent functional outcomes. You explain that, and then with that, you together with the patient's surrogate, then you can come up with goals of care. So I also want to say that goals of care is a dynamic process. Just because we made decisions yesterday does not mean tomorrow the same decisions cannot be changed. So this is a very dynamic process, because you know very well in critical care, the patient condition changes by the day, even by the hour, and sometimes even minutes. So what was decided yesterday can still be undone today based on the new findings on how the patient has progressed. And be very open to change this and to keep adjusting it in discussion with the patients and the patients' families so that you allow for a good concordant care. So one of the approach that really helps when I was looking at the data is called the REMAP approach. So the REMAP approach allows you to follow a systematic stepwise approach. And the first thing is to reframe. Because you're a clinician, you're supposed to use language that the relatives, the surrogate, remember the person making decisions for a critically ill patient may not be the patient, the patient may not be able to make decisions. So it may be actually as a patient surrogate or next of kin. So you need to rephrase and reframe. Avoid using medical jargon and break it down to a very layman term that the relatives, the surrogates, and the next of kin can understand. Number two is to expect emotion. Allow the relatives, the surrogate, the next of kin to express their emotion. Because once you tell them, this patient is doing 1, 2, 3, we feel this is the trend of the patient. Of course, any one of us will have emotions. I'm sure we probably had critically ill patients and we've expressed emotions. So expect emotions during the meeting. Number three, it's important to map out the future. And the future may just be one day. So it doesn't have to be a very long future. Because as I said, it's a dynamic process. And what you map out today may change. And you might have to map out another future tomorrow, depending on the patient's progress. So it's very important to map out the future. Mapping out the future means understanding once the surrogate or the next of kin has understood, then together you map out what are your plans for the future. Remember, very importantly, to align those with the patient's values. So when you're mapping out the future, if indeed the patient had already expressed that I do not want to be put on a mechanical ventilation, you remember to align, because some patients give what we call advanced directives, and I'll come to it shortly, where they are able to say, I don't want this and I don't want this if ever I am in a critical condition. So remember to align with the values of the patient. And some patients, because of religion and all these other cultural practices, they have certain values that they deem very important. So remember to align. Lastly, but not least, then you plan the treatment that match the values. So if the patient had initially said, I don't want to be ventilated, then you know very well that your planning cannot include ventilation. If the patient had said, oh, my religion doesn't allow me to have blood transfusion, then you know very well your plan cannot include blood or blood products. So remember the REMAP reframe.
We've lost you, Dr. Kagima.
Layman language, expect emotion, map out a future that aligns. Can you hear me?
Yeah, we can hear you now. We can hear you now. Yeah.
All right. Sorry. Please alert me if you've lost me. So I keep talking about a surrogate. Who is a surrogate decision maker? A surrogate decision maker can be a member of the family or anyone nominated by the patient when the patient was competent. And surrogacy is very important because this person has a very important role in making decisions when the patient is incapacitated. And I picked this from the Kenyatta National Hospital. We have a critical care policy document where we defined the surrogate decision maker. So this is just a member of the family. It can be anyone, really, that the patient had nominated or the relatives nominate that the patient is the one who is going to be the final decision maker, make the decisions on behalf of the patient. So I've also mentioned this term, what are advanced directives? Advanced directives, these are advanced decisions or guidelines that the patient usually says and plans before. Like for example, you can decide, if I am ever in a road traffic accident and I get very critically ill and no amount of care can take me back, then do not intubate me. So that's an advance directive, like a living will. So you actually authorize doctors to not do certain things when you are in an incapacitated state. And that we call that advance directive or living will, or even advanced decisions. And some people actually make this when they are competent. So it's very important that we remember that when you're making goals of care, we have to document. We really need to document. Do not make goal of care by just listening. You need to document. And you know what? There is no standard way of how to document the goals of care after a discussion. So different hospitals have different ways of documenting. I have looked at the documentation for Kenyatta because we worked on it. It's a little different from the Aga Khan documentation. It's a little different from the Nairobi Hospital and other hospitals. So there's no standard way, but we agree on certain things that need to be clearly outlined when you're deciding the goals of care. Number two, when you're documenting the goals of care, you need to have an explicit discussion. So whatever was discussed, I mean, this is where you write word for word what the patient or the relatives felt, you express it, explicitly document that. Thirdly, describe and reflect on the patient's stated values, goals, and preferences. These all need to be written there. If the patient says, I do not, my religion doesn't allow me to have blood or blood products, or the surrogate says the patient had already said they do not want to be resuscitated, all these things need to be written down and in line with the patient's values. So when we look at the documentation, when we are looking at the goals of care, because when we discuss de-escalation, basically.
Dr. Kagima, are you getting lost? We're losing
We
you.
cannot discuss de-escalation without discussing goals of care. Can you hear me?
You can go back a bit.
Can you hear me now?
Yes, I can hear you now. You're loud and clear. Okay.
All right. Did you get the slide? Did you get
the last?
this?
Yes.
Okay. So when you're talking about documentation, there are core elements that need to be written in that document. The location, where did the meeting happen? The location. Most of the ICUs have a family meeting place where they meet. Number two, the patient participation, or the family, who are there. If the patient is not is incapacitated, who represented the patient in that meeting? So write out their names and their relationships to their relationship to the patient, and also their contact information, because as we said, this is a dynamic process and it keeps changing. Then you have to write the clinical team participants. Like in our unit, we usually have the counselor, we usually have the doctors, and even the nurses join us. Make sure you write their names and what they do. And sometimes we even have more palliative team joining us. Please outline the clinical team and their role. Then you have to write any pre-existing advanced directives. If the patient had any pre-existing advanced directives, they need to be noted there so that all the plan aligns with the patient's directives. You also need to write to document what is the patient or the families or the surrogates' understanding of the prognosis. It's very important that you hear from them. What are they understanding about the prognosis of the patient? Then you also need to write the patient's identities and the patient values. If they are, religion, cultural, all these things come to play. Worries, all these things need to be written down. Lastly, after the discussion, you need to outline what are the specific therapeutic goals identified and do a plan, recommendation. And this involves whatever the relatives or the surrogate have said, that needs to be captured in the recommendation. So what is de-escalation of care? Now that we've talked about goals of care, de-escalation of care is basically withdrawal or withholding of therapy, where you decide that, and the biggest issue, and this is where I say now the line is very blurred. The question, can we withdraw, can we withhold therapy, is a medical question. But then there's an ethical question. Should we withdraw therapy? Should we withhold therapy? That becomes an ethical question. So de-escalation of care is both a medical and an ethical practice. Because can we, should we? And the line, it's usually said, the line between prolonging life and death basically shifts with scientific advances. As we advance more in science, like now we can get to know when patient is brain dead, even from an MRI, you know, science is shifting. Then that line of prolonging life or death shifts. And the question, I don't have an answer. And this is this question is made on the basis of patient by patient. When is it okay to not start? That is withholding. When is it okay to not start? And when is it okay to stop? That is withdrawal. So this does not, there's no one correct answer for each and every patient. So these are very blurred area. But just remember, when you're de-escalating care, you're either withdrawing or withholding. And you're both doing, that's a medical question and an ethical question. So when do we start to de-escalate? Routinely, de-escalation is considered when you have organ dysfunction that does not respond to treatment and your goals of care cannot be achieved anymore. That's why I said we cannot start discussing de-escalation of care before we even discuss the goals of care. Because when we know that, oh, this organ dysfunction is not responding to anything we do, and our goals of care are not being achieved anymore, then we start thinking about having the conversation about de-escalation. Or when life support becomes non-proportional to expected prognosis. Secondly, it's when life-sustaining therapies, these therapies are unable to meet the patient's goal, and it becomes burdensome more than beneficial. Then we can start discussing about de-escalation. And remember, de-escalation, you're talking about either withholding or withdrawal of care. So I came across this, which we were taught during our clinical ethics course, the 4-step Schumann's approach of when you consider de-escalation, or that is withdrawal or withholding. One, you need to have medical indications. You have to consider beneficence, non-maleficence, that's do no harm, goals of treatment, and probabilities of success. Secondly, you have to consider the patient's preferences, because remember, the patient has autonomy, and the patient, some patients give advanced directives, and some surrogates make decisions on behalf of the patient. So patient preferences also, needs to be considered. Thirdly, the quality of care. And the questions you need to ask, are there plans to forego treatment? Are there plans, is this a palliative patient? Is there a prospect for a return to normal life? And sometimes, honestly, these questions are very difficult to answer. And it's not one person who can make this decision, because sometimes we have thought, and I know for you who work in critical care, that there are patients who've thought, oh, this patient, according to us, we are not very sure that this person will return to normal life. And they've gone ahead and proved us wrong. They've improved. In fact, we've discharged some after many, many months, you know. So that's why quality of care is very important. And it's very important to remember that goals of care are dynamic. You can always change. And lastly, it's very important to consider contextual features. That's fairness, financial issues, you know, loyalty. I mean, all these things, family contextual issues, all these things need to be considered as you make that decision whether to de-escalate care. So let me show you an example. This is a form. I basically typed the form that we have, and I think a lot of our private hospitals have, that the doctor assesses for change of care of goals. And this is de-escalation of care. But because de-escalation of care is not a very friendly word, so we never write de-escalation of care goals. No, this list is usually in our goals of care form. But it does allow us, in choosing yes or no, it does allow us to de-escalate. So, and remember, this form has to be filled both by the patient and by the doctor. Usually, we advise that the doctor fills independently first. Why? Because you know, you are the expert. So you fill this form. Most of the forms have the doctor part and the patient or the surrogate part. And the same questions are asked. CPR, would CPR benefit this patient? As a doctor, you tick yes or no. Transcutaneous cardiac pacing, would it benefit? Yes or no. Defibrillation, yes or no. Advanced air management, yes or no. Artificial ventilation, you look at, would this patient benefit care in the intensive ICU? Yes, no. Would they benefit from care in the HDU? Yes or no. Would they benefit from total parenteral nutrition? Yes or no. As a doctor, you remember you're feeling this based on your expert assessment. Hemodialysis, would they benefit? Yes, no. Hydration, would they benefit? The same question, the same answers. Aggressive antibiotic therapy, you write there. Blood and blood products, according to your professional, remember this is the doctor feeling, according to your professional opinion, expert opinion. Lab and radiological investigations, would the patient benefit? Yes, no. And any other interventions that are not outrightly listed here, you can add them on this list. Now, when you have the meeting with the patients, then you see the patient will also fill the same form. Do you want your patient to have CPR? Yes or no? And remember, they cannot answer yes or no if they do not understand what CPR means. So that is why we said the first thing is to reframe, use layman language, whereby what is CPR? When do we do CPR? These relatives or the surrogate or the legal person must understand what CPR is. They must understand what defibrillation is. They must understand what is an advanced airway management clearly for them to be able to say yes or no. That is why we reframe, use layman language. Do you want your patient to have parenteral nutrition? If you just write it like that, patients don't understand what is parenteral, they just know food, you know? So you must explain what is parenteral nutrition and the examples and everything about parenteral nutrition, even the costs, okay? Hemodialysis, you must explain what hemodialysis entails. You must entail what hydration entails for them to be able to pick yes or no. Remember, the surrogate is filling this form independent after properly understanding exactly what all these things are. Blood and blood products, lab and radiological investigation. I'll tell you, recently in one of the private hospitals, we actually, the surrogate refused to sign for an MRI for a palliative, that patient was on palliative care, cancer, because the MRI, the question they asked was, is the MRI going to change? Can you hear me?
Yeah, we can hear you now. We can hear now.
All right. Is the MRI going to change my father's prognosis? That was the question that was posed. And the answer by the expert was no. And they said no. Okay, so all these things need to be signed, and it doesn't make them bad. It just, when they know, then they're able to sign these decisions from an informed position. So what happens? I know most of you are asking, so what happens when the doctor signs this and the patient signs that? That is completely allowed. If I feel like this patient would benefit from advanced airway management, and the relatives don't feel like the patient would benefit from advanced airway management, despite my explanation and them clearly understanding what an advanced airway management is, it is okay. So we have to respect the patient's values, or the surrogate's values, because the surrogate is the patient speaking. It's someone speaking for the patient. And if we feel that maybe the relatives have signed something as a no, and yet the doctor really feels that this thing needs to be done, then we've had to have several meetings. I know that the people who work in my unit, that's Kenyatta 7A CCU, we had a patient who the relatives refused a gastrostomy tube. And they said, we don't want, because they had already signed a DNR. And we really had to have like 3 meetings or 4 more meetings before they accepted, because according to the doctors, we felt that the gastrostomy tube, which is a feeding tube, would be beneficial for the patient, even if the patient is, it will not change the outcome, but it will help feed the patient. And we had, I think, 4 more meetings. I know the members of our team would know that, before the relatives finally said yes. So they actually said yes about 2 weeks ago, and we are in the process of that. So sometimes it maybe takes several meetings for them to understand. So do not beat them, do not do not force them to say yes to something immediately. Sometimes time solves the dilemma. So what triggers you as a clinician? What are the suggested triggers for family meetings, so that we can discuss goals of care and de-escalation of care? Remember, de-escalation is under goals of care. So there is no form written de-escalation. You will find in most critical care units, you'll never find a form written de-escalation of care. No, the form will always be goals of care form. But in that form, you can be able to de-escalate. So some of them is when you see the patient is going to have a longer stay in ICU, when you think from your assessment that the mortality risk is more than 25%, that can trigger family meetings and discussion. And remember, it's a dynamic process. So if the mortality risk was high today, and in another 5 days, the patient has turned around, then another meeting needs to be called. So any change in the patient's condition, either a decline or an improvement, patients who are more than 80 years of age, it's always important, and presence of 2 or more comorbidities. And if you ask, I always say, if you ask yourself a question that would you be surprised if this patient dies? If the answer to you is no, then you should call for a family meeting. And of course, there's procedure-based criteria where the family requests for a meeting. Like in our ICU, the family has a right to request for a meeting, and we always honor. Secondly, where you want to do a procedure like tracheostomy, feeding tube placement. I've just told you of an example of the gastrostomy tube. So we cannot do these things without permission. Renal replacement, if you want to start dialysis, any surgical intervention or any cardiology intervention, you need to call for a family meeting so that they can consider. And I just want us to go through how we talk, because in all these things, de-escalation of care, goals of care, how we communicate as clinicians is very important. So I'll just want us to spend a little bit more time on this slide. Like, the first objective is to create the right setting and open the family meeting. So use sample phrases to use thank you for taking the time to come in and talk about your mom. Then find out from them, how are you doing with all this? And then tell them, I want to make sure that we all understand what we need to do so that we can give her the best care possible. So avoid using dominant tones in meetings. Please remember that these are humans and you're expecting emotions. So, and then in terms of probing for understanding, you can use a phrase like, tell me what you know about your mother's condition right now, because then they can tell you in their own words. And telling you in their own words helps you achieve two things. One, you're able to understand whether they really understand the mother's condition at the moment. And secondly, you're able to tell how much they know so that you know what to add. And then avoid, I'm not sure if any of the other doctors mentioned this, but your mother has cancer or heart attack. You know, that doesn't sound very empathetic. Then another one, deliver prognostic information. Use phrases like, your mother is very sick. While we are doing everything possible to help her pull through, there is a serious chance she might not make it. Then you're supposed to pause. Most of us sometimes don't forget that pause, we keep talking. And then you say, if she does, she will likely be so weak, debilitated, that she'll not even go home for a very long time, if ever. So do not use terms like, well, things look very grave right now. You never know, things could turn around for the better. You know, don't give false hope. If you feel from your expert opinion that the patient honestly is sick, and I think it's something I used to do, give false hope, but then I remembered it's a dynamic process, which means today's meeting might be different from tomorrow, and allow that to happen. Allow that to happen. Then, of course, elicit goals, values, fears. A phrase, tell me about your mom. What kind of a person is she? What kind of things are important to her? What do I need to know so that I can provide her with the best, you know, just find out, remember to make this person feel as human as possible. So don't just focus on treatment and procedures. Do you want us to do the feeding tube or not? You know, and perhaps maybe the family I was talking about did refuse the feeding tube. Maybe the first time we put it that way, you know, maybe, because every human is to error. And maybe the relatives didn't see the need of the feeding tube. And it took several meetings for them to really appreciate the need and actually give a yes. If we go on, expect emotions. Please allow them to express their emotions. The other one, make appropriate treatment recommendations grounded in the patient's goals and values. Remember, it's never about the doctor alone. It's about the focus is the patient. So avoid using things like, I think we should stop aggressive therapy. My recommendation is withdraw care. No. And then the terms like, do you still want us to keep doing everything? No. Break it down. Break it down. An example, your mom took the trouble to let us know how she felt about the treatments at the end of life. We should honor and respect what she told us. Based on your mom's priority, I recommend we start dialysis. Then let's see how things go and plan to meet in the next 48 hours. So you're being very specific. I'm talking about dialysis. I'm talking about feeding tube. I'm talking about nutrition. I'm talking about airway management. I'm talking about, you know, break it down. Don't just call it withdraw care or doing everything. What is everything, you know? And you can see the form I showed you breaks it down to small little pieces for them to be able to know exactly what needs to be done. And lastly, summarize, strategize, and adjourn the meeting. Avoid saying, if you have no more questions, I think it's about, that is about all we have to cover. Tell them, I'm sure you will think of additional questions. Please write them down. Like in our unit, we usually tell them, if you have other questions, please, we have a doctor 24 hours. Talk to them, ask them, so that they know that the door is always open. If they go out there and discuss and see, oh, doctor told us this, and I know we said this, but we've thought about it differently, or we have another question, they always know that that door is open. And of course, tell them, let's meet again on Friday for another update, or if you wish for us to meet earlier than that, please let us know. So allow them, ensure that they know that the door is open for them to come back. So what pitfalls should we avoid when we are doing this escalation of care? One is biasing the conversation. You want them to choose the decision that you think will benefit the patient. And sometimes it doesn't allow with the patient's values or the surrogate's values. And then number 2, trying to deliver serious news and goals in one sitting. And that's something we all do. I think I've done it so many times where you deliver, your mother is not doing so well, and goals of care. You want goals of care immediately in the same sitting. Sometimes it's too much to chew. Maybe break it down. Today, deliver the serious news, the prognosis. Then tell them we'll meet again in 24 hours, to discuss the goals. So try and avoid, unless it's really dire conditions where the patient does not have that 24 hours. That is when you discuss the serious news and goals in one sitting. But if you think that the patient probably has time, start the conversation, but don't tell them it's not time to discuss. I want you to think about it. I don't want you to make any decisions. That's another way to deliver. So you tell them at the serious news, you tell them about goals, but you don't ask, now, I want you to sign yes or no in one sitting. No, give them time. And then let's avoid expecting too much too soon. Like in our recent case, we were taught that it can take 4 other meetings for relatives to come around. These relatives made a DNR decision very fast, but then the feeding, in terms of fixing the feeding tube, took us another 4, 5 extra meetings before they made that decision. So let them go at their pace. Then, starting too late or not at all, don't wait. The minute the patient enters our unit, I think we have a very good counselor called Maggie, who ensures that within a day, 24 hours to 48 hours, we already have a meeting to appraise the relatives of the condition and where we are going, and to just talk about what are we doing and where are we. And I think that's very important. We shouldn't wait too late or not at all. So I will talk about this, but I want to make it very clear that euthanasia is not allowed according to the law of Kenya yet. But there are 2 types, but just because it's part of de-escalation of care, even if we don't practice it. Euthanasia is a practice of ending life for reasons of mercy. And there are 2 types. We have the active euthanasia, which is deliberately ending someone's life. And then we have the passive euthanasia, which is allowing a person to die by withholding treatment. And I think the one that is a lot practiced here is the passive one, because withholding or withdrawal can be practiced, but the laws of Kenya, I want to be very clear that it doesn't allow euthanasia, but anyone can comment about this if there's anyone who knows more of this. So in summary, what have I been talking about? Goal is not synonymous to my clinicians. I really need that to sink, because
Dr. Kagima, we've lost your presentation.
Can you hear me?
Yeah, you can bring back the
sorry.
the last slide.
Yeah. Okay.
We lost you. I think it's the internet.
The summary. Did you lose me at summary?
You can start with the summary, please.
Yeah. Okay. So as I said, goal concordance is not synonymous to providing treatment perceived appropriate by clinicians. So do not forget that. It's basically aligning treatment plan with appropriate patient's values. Then secondly or thirdly, This de-escalation of care means compassionately delivering accurate and prognostic information, whereby you must be
I think your internet on your end has an issue.
Compassionate and very understandable. Can you hear me? Can you hear me? Can you hear me? Yeah.
Oh yeah, we're not hearing you, getting you clear.
Okay, sorry, I'm almost finishing. Then lastly, please remember to have an interdisciplinary strategy. We work a lot with the palliative team. We work a lot with the counseling. We even have a counselor in our unit. So you cannot work alone. You have to work with other disciplines to ensure de-escalation of care is done in a humane way. And my last quote is, medicine is inherently a moral enterprise. When you cannot be certain, because there are so many things we cannot be certain. We think the patient is going to die and they survive. We think the patient is going to survive and they die. The least you can be is responsible. Thank you.
Thank you very much, Dr. Shakli. There are two questions that have been posed by Jane Mwangi and Monica. Before we get to their question, there's a question that has really been troubling me. Now, how do you go about, or how do you approach a patient involved in a road traffic accident, brought in a department, is intubated, and then later on, diagnosed with severe head injury, brainstem dead? There are no documents, the relatives were not ready. How do you go about de-escalating the care?
So you have a, just to repeat what you've said, so you have a patient who was brought with a road from a road traffic accident, right?
Yes, yes.
Yes, brainstem, have you done you've done a CT scan or an MRI?
You're breaking off.
Can you hear me?
Yeah, now we can hear you correctly. Yeah. The patient is brought in from the scene of accident. He's intubated as part of a rapid intubation is done. The patient is diagnosed with severe head injury, brainstem death later on, but still in the department. How do you go about the de-escalation of this case?
So first of all, do you know the relatives? Sorry.
The relatives have just been informed about the issue. They didn't know about it. They're now in the department.
Okay. So yeah. The first thing that I would do, Kimanthi, I would first bring the relatives up to speed on what I've already done. You must bring them up to speed that you've done 1, 2, 3, and this is where you are. And I wouldn't discuss de-escalation of care on day one. As we've said, you cannot deliver you cannot deliver goals of care with de-escalation of care on the same sitting, because they've just come. As much as you know the patient is brain dead and the patient is not benefiting, I would allow them about 24 to 48 hours to first understand where the patient is at. And then now I tell them to come the next day, we discuss about the brain death and what it means. And if they understand, you allow them a bit more time for them to make the decision, because brainstem death is equals to death. To a clinician, that is very obvious. But to a relative, brainstem death in a person who's just had a road traffic accident can be a lot to chew. So I would allow them time to first sync the message before now we discuss de-escalation of care.
Okay, thank you. We have Jane Mwangi who poses a question. Do the patient wishes need to be documented?
Yes, Jane. You must document the patient's wishes in the goals of care form. I say we don't call it de-escalation of care form, we call it goals of care. You must. So if the patient did not wish to be resuscitated, that needs to come out very clearly.
Okay. We have an anonymous attendee who poses a question. There is a trend to withhold hydration and nutrition on ethical basis. Please comment. I'll also want to combine it with that of Elizabeth Julius. A wonderful presentation. Would you consider prescribing anticipatory medicine, e.g. morphine, Buscopan, etc. for pain relief to keep the patient calm as active euthanasia?
Those are very hard questions. I think I see Prof. Anyoro here. Maybe you might have to unmute some of the panelists to help me, especially on matters of euthanasia. I really avoid. Sorry, can you hear me?
You're breaking off. You can raise a hand and then you'll be unmuted.
Okay,
Prof, please.
Can you hear me?
You're still breaking off, Doc.
Okay, I think I can unmute myself.
Okay.
Go ahead, Prof.
Yeah, thank you, Jackie, for this wonderful presentation. I think it's an eye-opener for all of us. And of course, most of us do not work in situations where, like in ICU situations, where these hard decisions like these ones must be made. But that said, I think, as you rightly said, the main thing is to respect the patient's wishes. Two, the surrogate. And when you look at the surrogate, of course, in our situation, sometimes you may get a surrogate or surrogates who are more inclined to what they will get if care is withdrawn to a patient than to be really in the interest of the patient. So the issue of interdisciplinary approach where you involve various disciplines so that even these relatives or surrogates are assessed on the intention. Is it to the best of the patient? Because at the end of the day, whether we withhold or we continue with the care, it should be as to the best of that patient. So, of course, as you have rightly said, euthanasia in our country is a no-no. Of course, it is not there in the laws. It is not allowed. And I don't think we should discuss it here. So when you look at it, like in a patient who is terminally ill, maybe they have malignant lesion and they are terminally ill, we want to do what we always say, to add life to their days and not more days to their life. So making a patient comfortable with pain relievers, ensuring that the patient is comfortable towards the end of life, I think this is most critical. And I don't think it is part of what you'd call as euthanasia. Thank you.
Can I also add something, Kimanti?
Yes,
Yeah.
Go ahead.
Yes, so prescribing pain treatment can also bring up the principle of double effect. Yes. The principle of double effect is where you have an action can cause a serious side effect while promoting some good end or some good intended result. So for example, morphine can be associated with serious adverse effects like respiratory depression, right? But your justification is that the patient is terminally ill and there was a need to relieve pain and suffering, but then the patient dies because of respiratory depression. So I think we need to be careful. And I think what Prof. Anyoro has said is, I would call the palliative team so that they can help me dose the morphine in a way that is safe, because I don't want the double effect. Double effect can happen. And did the medicine kill the patient or did the disease kill the patient? These are questions that are left to be answered. So pain is good, pain management is good, but please do it within an interdisciplinary format.
Okay, thank you very much, Doc. So now we have a question by Monica. She's asking, whose decision is it to assent for CPR when there's a conflict of interest among the family? I'd also want you to answer together with the question from anonymous attendee, where they're asking about de-escalation of care. Can de-escalation of care happen in general wards? What do you do if the family and relative requests the machine to be switched off? And does escalation of care apply in pediatrics if parents take a route that is not in the best interest of the child? Go ahead, Doc.
Okay, there are many. So I will start with the one for if the relatives are not agreeing, then you can remind me the others. So
Yes.
anytime, like if CPR, maybe the relatives are not agreeing to what, some are saying yes, some are saying no. Usually remember the person who with the greatest power of decision making on behalf of the patient is the one with the medical power of attorney, or
Yes.
in the absence, the next of kin or the surrogate. So usually, and I've actually come across this in a polygamous institution where one person was saying this, the other person was saying that. And it all ended down to the person who had the medical power of attorney. What was the decision? Because if the others who are refusing are not next of kin, then you cannot, I mean, every family member has a different opinion, but it's very difficult because we are very cultural. So this is a decision that sometimes can be very binding. And this is where you call the lawyer. The hospital lawyer has to be on board. And probably this is a case I would take to the hospital ethics. Because remember, culturally, maybe the person refusing is considered as the leader of the family. You know, we have a very patriarchal society in some communities, isn't it? So all these come to play, and I would call definitely the hospital lawyer, and I would definitely call the hospital ethics committee to discuss. This is not my decision per se. This is not a one-person decision. Even if we know that this person holds the power of attorney, it is beyond me when the relatives are fighting. And because that could mean that these things destroy families. You know, death can actually ruin families if not handled very properly.
Okay. The other question was on this de-escalation of care in general wards.
Or de-escalation of care in general wards. I would only consider de-escalation of care in general wards if the patient has signed that they don't want to be taken to the HDU or to the ICU. Then I would consider de-escalation of care in general wards. But otherwise, if the patient or the surrogate or the person with the medical power of attorney has not expressively said, do not take my patient to ICU or HDU, then I think de-escalation of care in medical ward should be made on the basis of fatality. And I think this is where the palliative team should have been involved. I mean, in terms of all the discussion should have been made that you do not want the patient to go to a critical care unit. You know that the condition is fatal. So all these things, then yes. But if not, if the relatives don't understand that they have the right to go to an ICU or HDU, or the condition can be salvaged, then you're doing the wrong thing. But on some circumstances like cancer, honestly, stage 4 cancer, and you know that this patient is not going to, the prognosis of this patient is not good, then it can be done, but you need palliative team on board.
Okay, thank you very much. So now I'll combine these two questions, the touching on pediatrics. One, does escalation of care apply in pediatrics if parents take a route that is not in the best interest of the child? The other question is, can this de-escalation of care and prognosis information be practiced even in newborn unit?
A very good question. I don't know who can help. I will answer what I know, and feel free to probably pick up someone else who might be able to help me. I don't know, okay. But this is what I'll say. For pediatrics, the law is, I think, very clear. I think the law protects children that in case, and I'm a very good lawyer, but so I will not say quote to quote, but I think it says that in case the rights of children are protected, even from like their, like their primary guardians. So if the treatment will benefit the child, if the expert feel that the treatment will benefit the child, the law allows us to bypass the guardian, I think, but I would want someone else with more experience on that to comment. In terms of neonatal care, I think they are protected under children, that the experts, if the expert feel that this neonate can benefit from this care, I think the guardian can be bypassed lawfully. Is there a lawyer within our midst, Kemanthi, or an expert?
An expert, someone can raise his hand. We will unmute you from this end.
As they are unmuting themselves, but I just want to give my example. Like I think that we had a child whose parents were Jehovah's Witness, and we needed to transfuse in one of the private hospitals. And I remember, as much as the parent was refusing, the child was transfused because I think the law protects children. So, and I technically, and I could be wrong, technically speaking, a child may not have chosen, religion, they've been chosen for the religion, you know what I mean? So I don't know. If there's a lawyer, they can comment a bit more, but I remember that one particular case where transfusion was done on the basis that it would save, and the child lived.
Yeah, we have Dr. Nafula. She can
Dr. Nafula, please help me. I'm suffering here.
Yes, you are doing well, Doc. So when it comes to children, actually, children are not able to make decisions, and a lot of ethical dilemmas arise sometimes when parents make decisions that are not in the best interest of the children. We've seen some parents take their children for prayers instead of treatment. We've seen some declining treatment going because of religion or because of their own personal reasons. So I think for us in Kenya, the best approach is just to look at it from the legal point, where we have the duty of protecting the child. So these cases have been handled from time to time by the Hospital Ethics Committee, because there is really no clear answer of how to handle the situation. But we have to discuss each situation, look at the circumstances and see what is actually available. Because in extreme cases, we've had hospitals taking parents to court so that the court can authorize for treatment of the child that is in the best interest of the child. But before even getting there, internally, the Hospital Ethics Committee can still be able to try and get a solution for the child before we escalate it to legal now outside the hospital. Thank you.
Thank you very much, Doc, for the valuable input. We have a participant by the name Joylyn. She poses, what can you say about a patient relative calling from afar, maybe abroad, to be updated about patient progress by the attending doctor? Well, okay. Dr. Kagima?
Yeah, Kimanthi, I think, honestly, I'm one person who is not bothered by people calling from abroad to be updated. And I'll tell you why. It's because if you were the one in their shoes and your relative is unwell in a different country, just because they're in a different country doesn't, I mean, they should know, honestly. So I have no problem with giving them information. I usually just ask, how are they related? Important to find out is, one, how are they related to the patient? And secondly, you also seek permission to discuss with them from the surrogate or the person who holds the power, the medical power of attorney or the next of kin. As long as permission is granted, I'm happy to explain to someone abroad about what is happening. I don't usually have any reservations, but I have to seek permission from the next of kin.
Yeah, thank you. The other question by anonymous attendee is that how do you handle relatives who have an external medic advising them so they refuse care irrationally because of the external advice?
What I do, and what I think we've done that prior, is sometimes ask them, because sometimes relatives come and they say this is their family doctor. Then what we do is invite the family doctor for a meeting, together with if they are comfortable. Again, the person with the medical power of attorney or next of kin, ask them to bring that person, so that in the next meeting, so that you can hear their perspective and they can speak within a very open and free space. And what you basically do is make sure that you, as an expert reviewing the patient, you break it down and say, this is our plan and this is what we've done, and not to the person alone. They must be with the family. If they still decide to choose a different route because maybe the person is still advising them differently, then as long as you've given them the correct information, if you feel it will infringe on the patient's care, then we have the clinical ethics team. You push the case forward for further discussion. But usually I see that what I get is that once people understand, they work with you more often than not. Once people understand. If they don't understand, they don't work with you. And of course, there are special circumstances where people are just, there are many other contextual reasons why they would not want to agree with you.
Thank you. That question posed by Boniface is, what's the cost implication on prolonged de-escalation period when the prognosis is not good?
That's a very good question. And as I said, some of prolonging life sometimes can be a big financial burden. But I would say, as a clinician, it's not my decision per se that, oh, this is a big financial burden, so don't have it. It has to be the decision aligning to the patient's values. I've had the pleasure of working in private hospitals and seeing very resource-rich families choosing to continue with certain things, despite them knowing and fully understanding that it's fatal, and even sometimes even as big as even importing drugs from the country, just because there is a very small chance that this drug can change. So sometimes our hands are tied, as long as they understand. I always ask myself, do they understand 1, 2, 3? Yes. That the financial burden is there? Yes. Are they willing to take care of the financial burden despite fatality? And you keep talking to them, you don't stop. Remember, we've said that this is a dynamic process. So at some point, it will also dawn on them that this is fatal and we might not have anything more to do. But usually it's never my decision to stop just because I feel it's expensive. If they... Himanthi, can you hear me?
Yes, we can hear you now.
Yeah, sorry. Yeah.
Okay. Now the other question is about DNR, by one Rachel Marigi and Mary Ndegwa. They're inquiring, as a nurse, am I supposed to inquire about DNR, or is it doctor's duty? And how long is a written DNR valid? I think the span of a time, probably.
That's a very good question, by the way. Written DNR is only valid until the next meeting. As we said, you should have regular meetings with the family. Remember, it's a dynamic process. So that written DNR is only valid until the next meeting. So in each meeting, in a patient with DNR, we keep asking, you still keep asking, we are still DNR? Yes. And if nothing has changed, most of the time, patients, relatives, or the surrogate, or the person with the medical power of attorney don't change. However, if there is a change in the patient's condition, then it is your right as the expert to tell the relative that, you know what, we are now seeing this patient is doing 1, 2, 3. We think that there's a turnaround. And then sometimes the patient's relatives actually change the DNR, depending on your expert. You're supposed to give truthful information for them to be able to make a different decision or maintain the same decision the next meeting. So in short, your DNR lasts only until the next meeting with the family.
Okay, thank you very much. Brian poses, has the hospital ever considered putting together a committee that sits from time to time to assess all patients in critical care, to identify those from whom care can be withdrawn? Very interesting.
Sorry, just say that again. Has the hospital?
Has the hospital ever considered putting together a committee that sits from time to time to assess all patients in critical care, to identify those from whom care can be withdrawn?
I think what the hospital has done, and I'll ask Doc to also comment about this, is we have an ethics committee. What the ethics committee discusses are dilemmas, ethical dilemmas. I don't think the ethical committee has the capability of discussing each and every patient. And honestly, each and every patient doesn't need to be discussed. You understand? Because most of the patients are straightforward, and most of the patients, when you are open with the family, you will discuss with the family and things go the right way. The right way meaning that you both align, you as a clinician and the patient's values align. However, there are just those few ones, especially very sensitive cases where dilemmas occur. And those are the ones that should be forwarded to the the hospital ethics committee. So it only handles dilemma and not straightforward cases. And I don't think it's even fair to basically discuss each and every patient and see who care doesn't, But I think I will say this, ICUs should have an admission criteria. An admission criteria is a protocol whereby we prioritize patients. Like in our ICU, we have a protocol and we have priority 1 patients, priority 2 patients, priority 3, and priority 4. So if you're a priority 4, it means that, honestly speaking, we don't think ICU care will change the prognosis as much. And these are the patients now. If we have a competing patient who is a priority 1, we can make a decision that we will get the priority 1 into ICU for today and not the priority 4, because as you know, we are a resource limited setting and ICU beds are not enough for everybody. So that's how we apply a triage system when admitting into ICU.
Okay, so there's a question by George. In come-we-stay marriages, who should you deal with, the spouse or the parents?
I need help, Doc. Let me help you with that. Now, when it comes to a medical proxy, actually in Kenya, we are getting the practice wrong because we deal with the next of kin. We are supposed to get the patient to name for us a medical proxy. Who is the person that the patient trusts to make decisions for them when they're incapacitated? That person can be a spouse, it can be a relative, it can even be a friend. It does not necessarily have to be a relative. So the practice we have is that we look for whoever has been documented as the next of kin, and that is the person we rely on to make decisions when a patient is incapacitated. And as Professor Wanyoro rightly mentioned, some of these next of kins do not have the best interest of the patient at heart. Some of them even ask you, when is this patient going to die, so that they can inherit whatever the patient is going to leave behind. So it is important to know who is the surrogate decision maker, or whom does the patient trust? Is it the spouse? Is it the parent? So if a patient is able to talk for themselves, it is good for them to name for us a medical proxy before they're incapacitated. Thank you.
Thank you very much, Doc. This question, sorry, is there any law that guides in the end of life in Kenya, or what has been borrowed from other jurisdictions, Prof? Professor Wanyoro?
I am not very sure that we have a net of life law in this country. And I think this is the dilemma that we have always faced when you find that prolonging life is not in the best of the patient's interest and values. And I think this is the main thing is that we don't have any law that actually addresses this. But I'm not very sure whether there is any law in this country, but I've never heard of any. Of course, other jurisdictions, other countries, they have very good laws, and that's where you find even euthanasia has a room in management of patients. I think that's what I would say.
Okay, thank you very much. Back again to Dr. Nafula. Hi, can a DNR be requested by a family through a clinician if you feel the patient has a chance of survival? Dr. Nafula?
Sorry, please repeat. I didn't catch the first part of the question.
The question is, can a DNR be requested by a family through a clinician, though as a clinician you feel the patient has a chance of survival?
Okay, so DNR basically means do not resuscitate. And
Yes.
a DNR covers the active resuscitation, which is CPR and airway management. So I think when it comes to DNR, as Dr. Hagima has said, the DNR can always be changed. The best practice is for DNR wishes to come from the patient rather than the relatives. So DNR ideally should be done by people who are okay before the situation gets complicated. But again, when we look at the practice in our setup, sometimes we have to initiate the discussion or the relatives have to initiate the discussion. But it is important to know that the DNR discussion has to keep on continuing so that we affirm whether the DNR status is still the same, whether when the patient's condition changes, whether it changes for better.
Okay, I think we lost Dr. Nafula. Okay, the last question is, what does a signing against medical advice entail? Dr. Kagima?
Oh, that's signing against medical. There are many forms. They think of signing against medical advice. Basically, it means that you have explained to the patient or the person with the medical attorney that this is what we need to do, and you feel strongly that this patient will benefit from that care. However, the patient does not want that particular care. The patient feels that they have their own reasons on why they do not want that care. So that is when you make the patient, most of the time it's done by the patient. Like you don't want to discharge them because you feel they are still not well stable, then the patient insists, I want to go. So you make them sign a LAMA, leaving against medical advice, you know. So the forms are there, they're mostly filled by the patients themselves with full understanding of what are the implications. And if anything happens to them, basically, there is proof of evidence that you deterred them from leaving earlier, or you actually encourage that they should do one or two things which they did not. So it's very different from a DNR, if I may say. Yeah.
Okay, thank you very much. I want to invite the panelists to give a 2-minute closing remark. That is, we start with Dr. Nafula and then Professor Wanyoro.
Thank you everyone for attending this clinical ethics series. We'll be having 2 CMEs every month. So please watch out. The next CME will be on 25th August, and we'll be talking about advanced directives. And if you have any ethical dilemmas within the hospital, feel free to reach out to the Hospital Ethics Committee through the Patient Affairs Office. Thank you.
Thank you very much, Doc. Professor Wanyero?
I think mine is to appreciate the presenter. I think, Doc, you have done a very great job. This is an area that most of us are always worried about and thinking about. And you agree with us that medical ethics and the various dilemmas that exist are quite many. And of course, it is very challenging. So mine is to say that it is always important that whatever we do, we look at the patient values and the benefits to the patient as the first person. So we don't look at other issues like even cost implications, because at the end of the day, if there is a chance, then we don't do the escalation of care because of cost implication. There is always the issue of patient values as the first line that we have to consider. Thank you.
Okay, thank you very much, Prof. I'll take this opportunity to thank our presenter for today, Dr. Kadima, for the very informative and engaging presentation. Remember, the taking home message is that this is not about the doctor, but the patient. Always remember to remap. Thank you for joining us for this webinar. See you next time. Thank you.
Bye-bye. Thank
Bye.
you.
Bye.